Okay, so welcome to today's lecture. Today we'll be discussing vital signs as a caregiver based on the kind of patient you care for and where you work. You may be required to monitor your patient's vital signs in different occasions. So what are vital signs? They're called vital signs because they're important. They include 4 cardinal signs and 2 other signs that have been recently added. First is temperature, pulse, respiration, and blood pressure. And then there's pain monitoring, pain scale, and there's arterial saturation of oxygen. And in some situations, you may be required to measure your patient's height and weight. Vital signs and other physiological measurements can be part of the data before problem solving that would allow your physician or the nurse practitioner to be able to come to a diagnosis of what is wrong with the patient and what treatment strategy must be implemented. So you or the nurse or anybody who is required to measure or monitor a patient's vitals has to measure such vital signs correctly. Then you have to ensure that the equipment that you use are in proper working condition. Then you have to control environmental factors that may affect vital signs. For instance, if your patient is in a very chilly room, maybe you work in a country where they experience the extreme of temperatures, and temperature is in the negatives, chances are your patient's body temperature may be a bit lower than normal. So what do you do in such situation? You want to adjust the heater and be sure that the ambient temperature is within a normal reading so that you'll be able to have an appropriate reading for your patient. Then you should be able to understand and interpret values. Your patient has a temperature reading of 35. You should know that it's low because there's an expected normal range for every patient. Then you must be able to communicate your findings appropriately with your supervisor or with your nurse practitioner or with your managing physician. Then you want to begin interventions as needed. Should you find that this patient of yours has a temperature reading of 38, if it's a child, that may be a time to make the child have a bath. If it's an adult, that may be a time to give your patient paracetamol while you wait for the nurse practitioner or the physician to take over the care. And if you find that the blood pressure is very low, for instance, you may need to make your patients lie down so that they don't stand up and then pass out because the blood pressure has crashed. So now, temperature as one of such vital signs. What are some factors that may affect temperature? Age is a factor. Age in the sense that extremes of age, the very young, especially for newborns, and the very old may have their temperature reading very low, and it will fluctuate quite rapidly for those in those extreme of age range. Then exercise, after a lot of vigorous exercise, temperature may go up a bit and it's normal. It's not a disease state in such a situation. Hormonal influence is also a factor. Diurnal influences in the morning, the ambient temperature is usually lower, generally across board. But by evening or by late afternoons, if you are in the tropics, you find that the environmental temperature is quite high. And with that, there may be a bit of corresponding increase in your patient's temperature. Then stress, some environment, it could just even be the presence or the absence of heater, presence or the absence of AC in that environment that can alter the temperature a little. Then if your patient ingests hot or cold liquids, that could also alter temperature. Then a patient that smokes may also have some abnormal temperature readings. So temperature is a relative measure of sensible heat or cold. Sensible in the sense that you can sense it. You know, the 5 senses: sense of touch, sense of sight, of taste, of hearing, and of perception, of feeling. So you can sense the heat, whether it's hot or it's cold. That's essentially what temperature is. So you try to get a relative measure of that. So the body would always strive to maintain temperature around 37, but the range could be from 36.1 to 37.5 based on the facilities you work. Some facilities will give you a range of 36.5 to 37.2, but you know that is what you're going for overall. And like I said earlier, many factors that will affect body temperature would include the environment, the time of the day. Did you take that temperature reading in the morning or in the evening? Your patient's state of health, activity levels, and then stage of monthly menstrual cycle could also affect the temperature reading. So now there are two types of temperature. There's the core body temperature, there's the surface temperature. The temperature of the core body temperature is the temperature of the deep tissues of the body. That usually you'll be able to assess it with a thermometer. So the thermometer is either under the armpit, under the tongue, in the rectum. By the rectum, I mean you pass through the anus to go deep into the rectum. Or you're taking an oral temperature with some special thermometers through the ear. Now, for surface temperature, that many times is just the temperature of the skin. So that could just be you touching the patient's skin, like so, to feel for the person's temperature. So temperature measurements can be observed by several methods. There's something called heat patches, just look like a plaster that you just stick on the skin. If you stick it on the skin, you will then observe color changes on the patches. The color changes would be matched with the corresponding temperature reading. You would have that chart with you, and then you'll be able to take your reading. But the most common ones you will find are the electronic thermometers. That's a commoner one. Usually they are rechargeable batteries or they are just replaceable batteries that are there. Then there's a thin wire cord and a temperature processing probe. So you put such under the armpit, under your patient's tongue, just anywhere that is appropriate for temperature reading. And then there's a tympanic thermometer. It's a form of electronic thermometer and is usually inserted into the auditory canal for reading. That is not so common. The most common one you will find will be the electronic thermometers. So now this is one of such oral thermometers. This was the one that really made the waves during COVID because we're going for non-contact as much as possible in the hospital. You may still find this in your place of practice, but this is the most common one that you would see in, regardless of where you work. Chances are you would see this type of thermometer before any other time. So what are the signs and symptoms of elevated body temperature? If you find that your patient's body temperature is high, what are the signs and symptoms that you may observe? Your patient may be complaining of thirst. Your patient may have anorexia, may lose appetite, may not want to eat. The skin may be flushed. Those who are Caucasians, white-skinned persons, you'll just see that the skin is red, more red than normal, because there's increased blood flow to the skin and the cutaneous tissue. So the skin may be flushed, the skin may be warm. Then you may find the person is irritable, especially very elderly persons. They may be irritable, they may be confused, they may be disoriented, a number of things like that. Then they may complain of headache. You may find that the pulse rate and the respiratory rate would also go up because vital signs are interrelated. And you may find that your patient is restless or is excessively sleepy. You may find that the patient is sweating a lot. Now, in children may become disoriented and may even may progress to convulsion. So convulsion following fever is not unusual in children. For that reason, when you observe fever in a child you're caring for, even before you give any medication, the minimum you can do is to have that child bathed, just to see how you can begin to reduce the temperature. So oral temperature is, usually you put such a thermometer into the patient's mouth. You don't routinely obtain such temperature in a patient who is comatose because you may also care for a patient who is comatose. Someone who had head injury and is in a state of coma. Someone who had a stroke and is in a state of coma. Someone who has end-stage cancer and is in a state of coma. You would usually not want to obtain oral temperature reading for such a person. Or you have a child who is disoriented. Your child may bite the thermometer. So you want to go through another route. Now, rectal rectal temperature reading is also possible. I told you pass through the anus into the rectum to take your reading. But in someone who had a surgery around the anus, or someone who has a conditions around the anus and the perineum, you will not want to take readings there. So that then leaves you with the axillary temperature. Axillary temperature, you take it in the armpit. That's about the most commonly used one. The truth is the least accurate, but it's the most accessible, that you can easily tell the patient, please lift up your hand, I want to put the thermometer there, without much hassle, versus open your mouth, I want to put it there. A patient who is conscious, who is willing, who is cooperative, who is not demented. You know, we discuss Alzheimer's disease and dementia, so the patient may not even know who you are. But patients who are none of this, who is willing to cooperate with you and understand the procedure you want to take, and has given you the go-ahead, will most likely be willing to open the mouth, and then you can put the thermometer in the person's mouth. Okay, so I want to pause and take question here before we continue to pulse rate. Do we have any question, please?
No question, ma'am.
Okay, thank you. Okay, so we go to pulse rate. But while we discuss pulse rate, it's also good to discuss stethoscope, because you can take pulse rate with your hand. For some situations, you may need to look for pulse rate somewhere else with a stethoscope. So a stethoscope is an instrument that is usually placed against the patient's chest or back with two aims. Either you want to listen to the patient's lung sound, which may not really be your call in this situation, or to listen to the patient's heart. Maybe you need to you were told to count the patient's heart rate. Heart rate is different from pulse rate. Pulse rate, you get it from the hands, the extremities. For heart rate, you're getting it directly from the hand. So in such situations, you may need to employ a stethoscope, and this is what a stethoscope looks like. It has the earpiece. These are the parts that go into your ears, and then you have the bell and the diaphragm. So this is the part that goes to the patient's heart, and then you set your time and you count how many of those beats you can pick. So now when you are auscultating means you are listening with a stethoscope. So when you're auscultating with a stethoscope, you or the nurse usually, you're aiming to listen for the heart rate at the apex of the heart. Apex of the heart is where the sound is louder. What you're going for, let me get the heart, which is always on the left side of the chest. Let me place the stethoscope there. Let me put the stethoscope in my ear. Let me set the time and see how many I can count. And like I showed you earlier, I said the stethoscope has two parts. You have the earpiece, and then you have the binaurals. Those are the parts that are placed on the patient's chest. This is your binaurals, and these are your earpiece. So then that takes us to pulse. I told you apical heart rate or heart rate, as the case may be, you are taking it from the patient's heart region, usually on the left. But for pulse rate, you're taking from the extremities many times. Most times we use the radial pulse on this side and on this side. So the pulse is a rhythmic beating or vibrating movement. A normal pulse should be regular. So it's like a recurrent expansion and contraction of the artery that is produced by pressure caused by ejection of blood from the ventricles of the heart as it contracts. It sounds like a mouthful. What it just means is for each time the heart pumps, that pressure goes to the vessels, to the artery especially, and then you will now have that pressure transmitted as pulse rate. So it is that transmitted contraction of the heart and relaxation of the heart that we then decide to read or count as pulse rate. And your aim when you're taking a patient's pulse rate is to know the rhythm, the rate, and the volume of the pulse. Rhythm, a pulse should have a rhythmic beat. Then the rate, how many did we count in 1 minute? Did we count 60? Did we count 70? Did we count 80? Then volume, how strong is the pulse? Is it a very feeble pulse that you're even struggling to feel it? Or is it a very strong pulse that you can feel? Essentially, that is what it means. So now, pulse rate for adults is expected to be between 60 and 100 beats per minute. Why it's not impossible that you may also have a child that will need pulse rate at home. But most children, if they can be that unstable that they will need their pulse rate monitored frequently at home, chances are such patients Such children may be in the hospital. But elderly persons, many times you have that instruction to count your patient's pulse daily, do the blood pressure daily, and a number of other vital signs that may be required of you to perform. So when you're counting pulse, this is how you position your hand like so. And this is the practitioner's hand, and this is the patient's hand. So you're trying to firmly press the artery against the bone, and then you feel the artery beating backwards against your hand, and you count for 60 seconds and note what it is you have counted. Of course, you record it. Normal, you're going for 60 to 100. Less than 60 is abnormal. More than 100 is also considered abnormal. So then what are the factors that may affect a patient's pulse rate? Age is one of such factors. Younger persons usually will have a faster pulse rate. Exercise is one of such factors. So if your elderly patient has just returned from an exercise and you find that the pulse rate is 110, there may be no cause for alarm yet. You may just need the person to rest and repeat it in like 10-15 minutes time and see if it has come back to normal. Then fever, heat, generally, if the environmental temperature is high, you may find that the pulse rate goes up. If your patient has a fever, you may find that the pulse rate goes up. So you want to be sure, this is my patient that has a pulse rate of 110, which I know is abnormal. Is it possible that this patient of mine also has a fever? So I have to go ahead and check the temperature. Then if your patient has acute pain or your patient is worried, so your 90-year-old patient fell and sprained her ankle, she's in acute pain, the pulse rate may go up, understandably, because there's pain going on. Then if she has unrelieved severe pain or chronic pain, maybe the severe pain of arthritis, the severe low back pain, you may find that their pulse rate may go up. Then some medications will also affect pulse rate. It can bring it down, it can take it up. Then if someone is bleeding, pulse rate many times will go up. Then postural changes, if I change my position from a lying down position to a sitting position, the pulse rate will go up just a tiny bit. And then if I change from sitting position to standing up, it also goes up just a tiny bit. Then metabolism, and then pulmonary conditions. So a patient who has difficulty in breathing, who has chronic obstructive airway disease, a number of diagnoses that is very common with elderly people. You may also find that the pulse rate is different from normal. So there are two terms you will hear very often wherever you work, except if vital signs is not indicated as one of those things you have to do for your patient. But if it is indicated, you will hear these terms very often. You will hear tachycardia and you will hear bradycardia. So I told you normal pulse rate is 60 to 100. So tachycardia is pulse rate that is faster than 100 beats per minute. So I put my hand, I am reading, I set my time for 1 minute, and then I counted 120 beats in that 1 minute. My patient has tachycardia. And some things that can cause it would include shock, patient is bleeding, which is hemorrhage, patient has just returned from an exercise, patient has a fever, your patient has acute pain, or your patient is on some drugs. Now, bradycardia, if I set my timer and I'm counting my pulse, and I find that I have a reading of 55 in that 1 minute, that will be considered bradycardia because that is less than 60. And that again can result from unrelieved severe pain. Some drugs again can cause that. If you find that your patient is sleeping, like if you check such pulse rate when your 80-year-old patient is deeply asleep, you may be just low normal because she's sleeping. Or a patient who has heart block, some conditions that are again fairly common with elderly patients, the group of persons you would likely also be caring for. So dysrhythmia, this is abnormal. Rhythm is rhythm. So we already said you're checking for the rhythm. The heart, the pulse rate should be only be observed in persons who have heart diseases or heart abnormalities. So in such persons, they may have abnormal rhythms. You observe such, by all means, you want to also communicate with your supervisor or the nurse practitioner or the physician who is in charge of such a patient. So then that takes us Sorry about that. Network took me out. So I said the oxygen is taken in, is utilized by the tissues, then is given out as carbon dioxide. So it's essentially the act of breathing. That's what we call respiration in the medical parlance. So there are two arms of respiration. There's the inspiratory phase, there's the expiratory phase. Inspiration essentially means I inhale and I take in oxygen. Expiration means I exhale and I breathe out carbon dioxide out of my lungs. So what are the factors that can influence respiration? A patient that is diseased or is ill would either have very high or very low respiratory rate. A patient who is stressed, fever would cause respiratory rate to go up many times. Age, the older the patient is, the more abnormal you may find that the respiratory rate is. Gender, body positions, lying down versus sitting down. Lying down respiratory rate, if I am deeply asleep, will probably be slower than if I am standing up or I'm walking active. So you may observe such changes in your patients. Then medications, some medications will affect respiratory rate. Exercise, a patient who has acute pain, a patient who smokes, or a patient who has brainstem injury may have a number of disorders or dysfunctions in their respiratory rate. So the assessment of respiratory rate, if you are asked to go and check your patient's respiratory rate, would include the rate. How many did I count in 1 minute? So counting respiratory rate means I'm seated and somebody is looking at me and just counting how many times I'm breathing in and out. And the person sets a timer and says how many he or she can count in 1 hour. Essentially, that is what you do for your patient. So you're checking for the rate. So how many did I count in 1 minute? I'm checking for the depth. Is the breath shallow? Like someone that is not allowed, the breath is not really getting to the base of the lung. So you find the person breathing up. Then you observe for the rhythm. Is it rhythmic? As you can know that this person is just breathing very stably, or is the rhythm distorted? So normal respiratory rate for adults is between 12 and 20 cycles per minute. We call it cycles per minute, or just 12 and 20 per minute, 12 to 20 breaths per minute. So two terms you would also encounter in your practice. You hear tachypnea. Tachy just means fast. Brady means slow. So anywhere you hear tachy, you know that's fast. Brady is slow. So this is rapid respiratory rate that can be caused by exercise, fever, or some disease state. So you find that the respiratory rate is more than 20. Then bradypnea is slow respiratory rate that is less than 12 beats or 12 breaths per minute. So while you are assessing for the rate, the depth, the rhythm, and the quality, you also want to assess for, this my patient, does he have difficulty in breathing? Is the patient struggling to breathe? That may be a problem with rate, or a problem with depth, or a problem with rhythm. Then apnea means a lack of spontaneous respiration. So the patient's respiration ceases. That's what we call apnea. So that then takes us to blood pressure. At this point, do we have any question before we continue, please?
Not yet, ma'am.
Okay, thank you. So the blood pressure is exerted by the circulating volume of blood in the arterial walls. You know, I said earlier, as the heart beats, this pressure resounds on the wall of the artery. So that is what we then take in our reading when we're doing blood pressure reading. Blood pressure reading has two arms. There's the systolic, which is the higher number, the number on top when the blood pressure is written. And then there's the diastolic, which is the second number, the lower number. That's the number below when blood pressure is written down. So now, importantly, what you want to know is, what does a normal blood pressure look like? So there's this graph that I want to explain. So here is the systolic reading. Here is the diastolic reading. Your interest, by all means, is to be within this range here. By the time your patient is having anything above 140 for systolic, which is the number on top, or anything above 90 for diastolic, which is the number below, by all means, your patient must be seen by a medic. Your supervisor must know that something is going off. But then, supposing you're just doing normal monitoring within the house, you will most likely be having between 105 and 140. That's the upper number, that's the systolic for elderly patients. And you may have between 60 and 90 for your diastolic, that's the lower number. Now, it's also important to know that you may have some patients with 90, 60, and it is still normal, but that will not be the kind of patient you'll be caring for. Your elderly patients particularly, this is the graph, this is the chart that you want to be a guide for when you can tell yourself, okay, we have a safe reading. We don't need to call the supervisor, we can just record it. The upper number would be between the range of 105 and 140. The lower number will be between the range of 60 and 90. Anything outside of this, something is going on, and a crisis may be precipitated soon. So you have to reach out to the supervisor or the nurse practitioner, whoever is just in charge of the patient's healthcare aside you. So what are the factors that can influence blood pressure? Age, the older the patient gets, the higher the blood pressure goes. Then a patient who is anxious, who is scared, who has pain, who has some emotional distress, blood pressure may also go up. Some medications will affect blood pressure. They have the ability to bring it up or take it down. So your patient may be on antihypertensives. That is, a patient who has hypertension is also taking drugs for hypertension. The blood pressure may be dropping and it may drop precipitously below the normal. So such a patient, usually once they're sent home with medications, it's mandatory that their blood pressure reading should be done at least once daily. Then diurnal happenings, waking up very early in the morning, many times the temperature reading is still around the normal, a bit lower. But by the time the patient has done a bit of exertion here and there, by evening, if you have to record the blood pressure, you may find that it's just a bit higher than what you had in the morning. That is also expected, provided what you have in the morning and in the evening is still within the range of what we discussed. Then your patient's race and gender are also points to consider in blood pressure reading. So still more on conditions that can alter blood pressure reading. Hemorrhage, that is bleeding. A patient who is bleeding, blood pressure reading will drop down. A patient who has increased intracranial pressure, that is more common in elderly person, had an accident, fell and hit the head, and a number of things, has brain tumor, a number of conditions like that may have blood pressure readings that are low. Someone who has acute pain, like an 80-year-old woman who sprains the ankle, blood pressure reading could be low. Then end-stage renal disease, primary essential hypertension, and a number of other things. Many times you would know the diagnosis that your patient has. You will know the medication the patient has. Your call as the caregiver is to see to it that the patient's blood pressure is being monitored. And then if there are alterations or abnormalities, of course, you could communicate with your supervisor, but you would also then be able to tell, okay, so my patient has this condition, that's why this BP is like this. So blood pressure is measured with an instrument called sphygmomanometer. Sphygmomanometer. So there are several types. There is the manual that you would have a cuff that you can inflate. You inflate and pump it with your hand. Then has a gauge that takes the reading. And if you were doing a manual blood pressure reading, usually you will need a stethoscope, you will need a manual sphygmomanometer, and you will take up the cuff and then you listen for the sounds. So the sound to listen for are called chord cough sound. When you come for your practicals, the clinicals in the hospital, you have some hands-on experience about this. So this is one example of a sphygmomanometer. So it has the pressure gauge, it has the pressure gauge, and it has the inflatable cuff. This is also an example of a manual blood pressure reading apparatus. So this is the pressure gauge, this is the inflatable cuff. But most of the places you practice, due to the advances in medicine, you would likely come across electronic blood pressure monitors like this. These ones, you do not need to manually inflate any gauge. You just wrap it around the patient's upper arm here and set the reader around the cubital fossa. That's the elbow here in front. That's where we have very big artery. Again, you will get some hands-on practical when you come to the hospital, and then you press the power button and wait for the reading to come up. The reading comes up and you take your documentation. It's just as simple as that. So now when you're taking blood pressure reading, because you may work in the hospital for a patient who had a surgery, you may work in a care home, may work in somebody's personal residence. So you will not want to apply the pressure cuff if the patient has a catheter or a cannula. That is that thing we put in a patient's hand to give infusions, drips, to give medications. Usually we secure it and plaster it down. So if a patient has any of such on that hand, or the patient is taking a drip on that particular hand, you do not want to put a blood pressure cuff on that hand. We have two hands, so you go for the second hand. If a patient has had a surgery, there are some persons, maybe like a patient who has chronic kidney failure and is on dialysis. Many of them will have arteriovenous shunts in one of those spaces. So that particular hand is not the hand for blood pressure reading. It has to be the second one. Supposing you get to care for a patient in the hospital who had a surgery, maybe on the breast or in the armpit, the affected side that was operated cannot be used for blood pressure reading. Use the second side. Or a patient who had a fracture, a wound, a burn, or a disease on one arm, that arm would also not be used for blood pressure reading. It has to be the other one. Or someone who has a POP or a cast or has a bulky bandage because there's a wound that is dressed on one hand. You can't use that hand for blood pressure reading. It has to be the second one. So like I said earlier, there are automatic device monitors, which is the one I showed you, which is the most common ones you come across. There are still places that use the manual monitors, but they are not so common because, like I said earlier, there are some really wonderful advances in medicine. So they are the self-measurement kits that are just portable. They are small. They are in a small pouch, a small bag. They are in your patient's house. You take care of it and do your patient's blood pressure. And there are some you may find in the hospitals that are more, they are big. They are like stationary. You can't really move them around. They are also automated. You just wrap it around your patient's hand, press your button, and it gives you a very convenient reading. Now for height and weight. In some situations, you may also be required to measure your patient's height and weight, maybe daily, maybe weekly. So if for any of this is needed, considered as a vitals that should be measured, some concerns, some considerations may be that they want to assess the patient's growth and development that is normal. So that may be for a child. You want to see that this child is growing as it should. Or maybe a child is to be given some medications and the medications should be calculated by weight or by height. Sometimes you will need those two readings. Then a patient, like if your 80-year-old patient has heart failure and is sent on with some medications that is supposed to mobilize excess fluid out of the body, the way those drugs work, they are called diuretics particularly, is that they make your patient pee a lot. So your patient may be sent home with the instruction of daily weighing. So the patient's weight today may be 75, and then the patient is placed on diuretics because we want to mobilize excess fluid out of the body. And the patient is placed on daily weighing. Tomorrow may be 74. Now we know our patient is moving out the excess fluid. Next tomorrow may be 73 and on like that. So that's the essence of weighing such patients at home. Then a patient who also has significant weight loss because of underlying disease, and then they're trying to rehabilitate the patient back to a normal state of health. You may also need to monitor the weight to see if the patient is gaining weight as expected. So now when you need to measure your patient's height, the patient should remove their shoes and stand erect. Then a measuring stick or tape may be attached vertically to the weighing scale or the wall, and then you take your reading. And there's also some standing scales that have metal rod. You just pull it up, place it on the patient's head and take your readings. So now when you need to take weight, there are different types of scales, importantly for weight. A patient who can stand would use a standing scale. A patient who is bedridden or who is wheelchair bound will use chair scales. And when you have to weigh your patient, it's important you weigh the patient the same time every day. If the patient is placed on daily weight and you do decide that I weigh my patient by 7 a.m. before breakfast every day, 7 a.m. has to be 7 a.m. You can't weigh by 7, then you remember again the following day by 12, and then you weigh. By the time you're weighing by 12, your patient has had breakfast and has taken water. So that would also be added to the weight you're measuring. So you may find that you have weighed 71 kg today by 7 a.m. Then tomorrow I remember that I'm supposed to weigh my patient by 2 p.m. Patient has had breakfast, has had lunch. By the time I'm weighing, I find that my 71 kg is now 72. For a patient that should be losing weight, now it's gaining weight. It's not really gaining weight. It's just that now I have measured food and water that the patient has consumed that day. I should have stuck with my measurement at a particular time, preferably first thing in the morning, before food, before water. So we have the patient's real weight minus every other thing that we consume in the day. And when you want to weigh your patient, you usually will tell them to go and void. To go and void means they should go and pee before weighing. Reason is, in fact, for someone whose bladder is very full, you may have as much as 500 ml of water, of urine in the bladder. 500 ml of urine in the bladder is at least 0.5 kg. So for a patient that you really need the weight down to the nearest digits, you have to be very, very particular about it. So your patient has to go and pee before you place the patient on the weighing scale. So now these are the types of weighing scale that I was talking about. So this is a standing scale for a patient who can stand, a sitting scale for a patient who cannot, and also for a patient who cannot. So this is a lift scale. This lifts the patient. This is many times even for a patient who is bedridden. So there are some of those bed linens that can lift the patient. So they hook the ends of such linen to the weighing scale and lift the patient off the bed, and then you take the reading and drop the patient back on the bed. So when vital signs are assessed, should it be temperature, pulse rate, respiratory rate, blood pressure, they should be assessed usually at the same time or at set intervals. So if I plan to do a daily vitals reading for my patient, it should be 7 a.m. every day. If I plan to do it every 6 hours, it should be every 6 hours. Not that I remember to do one at 6 a.m. 6 hours from 6 a.m. should be 12. And then I remember another one at 4. That is not a 6-hour interval. That will be considered a 10-hour interval. And that may not give you a very reliable reading. So there are some kind of recommendations you may have, or prescription you may have for your patient reading. May be as frequently as every 4 hours based on the patient's condition. It can be once during your shifts. It can be once a week based on overall patient state of health. That determines the frequency of the blood pressure reading. Now, the more ill your patient is, the more frequent the vital signs will be taken. And vital signs are interrelated. For every 1 degree rise in temperature, many times you have the pulse rate going up as high as 4 beats per minute. What that means then is, if I find that my patient has a very high temperature reading and I find that the pulse rate is also going up, I understand that there's a correlation between the two of it. Or I find that the respiratory rate also goes up, I also understand that there's a relationship between it. So vital signs are essentially interrelated. But that also means that if I find that my patient has a temperature reading of 39, which is very high, and I find that the pulse rate is 50, which is very low, something is off. Something is very, very off. For temperature that goes up, pulse rate should go up a bit, corresponding with it. So there's a 5th vital signs that is called pain. And you would use pain scale in a patient who has chronic pain, has acute pain, a patient who had a surgery and was sent home with a caregiver. A patient may need to have a daily pain scale or even a 6-hourly pain scale assessment, because that would then determine the frequency of their painkillers and a number of things. So pain scale is rated from 0 to 10. 0 means the patient has no pain at all. Someone who tells you my pain is just 1. So the question you ask is, on a scale of 0 to 10, how bad is the pain? 0 being you don't have any pain at all. 5 being the pain is somewhere in the middle. 10 being is the worst pain ever. And the patient says, I think my pain is like 1. 1 means the pain is minimal. So the pain is hardly noticeable. For such a situation, your patient really may not need medication. They just need some supportive care. Someone who says the pain is mild, that's the pain of 2 on the scale. Means the person has a low level of pain, is aware of the pain only when he or she pays attention to it. Again, not a very bad pain. Then someone who has a pain scale of 3, it means the pain is a bit uncomfortable. So the pain bothers them. They cannot ignore it most of the time. At this point, usually intervention must be done either with the patient's painkillers, some supportive care, and some other instructions that would have been given to you by the patient's physician or nurse practitioner. Then somebody who tells you that my pain scale is 4, that's a moderate pain. So the patient is constantly aware of the pain and they cannot continue most activities. Again, this has to be, this kind of pain needs intervention. Someone who gives you a pain scale of 5, that is significant. So the pain is distracting. Essentially they are focused on the pain and they would not be able to do activities of daily living. So someone who has severe arthritis and is in constant pain, such a patient will probably even need assistance to be able to go to the toilet and a number of things. Then by the time you're having pain scale 7, 8, 9, 10, such pains many times will not be in your hands. Those pains are hospital grade pain. They are admission level pain. So such patients many times are in the hospitals. The ones you would most likely be managing at home will be between the pain of 1 to 5 on the pain scale. Okay, so what this also now means is that if your patient tells you my pain is 6, is 7, is 8, is 9, is 10, within the shortest possible time, you want to get your supervisor or the managing physician or the care or the nurse practitioner, either the patient gets a home visit from them or the patient gets moved to the hospital. Pain scale of 6 to 10 are not pain scales to be handled by a caregiver. Okay, now supposing you have a child who cannot give you so many words to explain what the pain feels like. It may just be the facial expression you would observe. If you look at this first picture now, you can see this person is smiling, no pain at all. And now on a pain scale of 1 to 2, the person is not smiling, but the pain is considered mild. By the time you get into 3 to 4, there's a frown or a sad face. And by the time you get into 5 to 6, this person really looks in a pretty bad shape. And by the time you get into 7, 8, 9, and 10, your patient is probably crying or wincing in pain or screaming out or rolling about in pain. So those are not pains you want to keep again in the house. Those are not pains for caregivers. Those are pains that should get to the hospital within the shortest time possible. So the final one is arterial saturation of oxygen. So it's monitored for patients who has chronic lung diseases, patient with heart failure, just a number of chronically ill patients. So some of your patients may be sent home with the instruction to have the arterial saturation of oxygen monitored. So many of such patients will have the apparatus. It's for you to know what it is. So it refers to the blood oxygen saturation that is measured by the percentage of the hemoglobin of the blood that is carrying oxygen. So hemoglobin is a protein in the blood. The blood has red blood cells. Hemoglobin is what carries oxygen and moves it around in the body such that the body has oxygen to utilize. So SpO2 essentially is just like a percentage of the hemoglobin that is carrying oxygen. So we expect a normal reading of 95 to 100%. That is considered normal. So the device we use is called a pulse oximeter. Usually you clip it on the patient's finger and you take the reading. So normal range, your patient that is healthy, no hassle, would have a reading of 95 to 100. Now, many of the patients you care for would have 90. 90 to 100 is considered normal for them because they have chronic diseases. So chronic lung diseases, sleep apnea, chronic heart failure, and a number of such conditions, they may not have readings as high as 95, they may have 90, and that is considered normal. So usually when such a patient is sent home, you would be instructed that this is what we're targeting. We must not have less than 90. So we have 90, we're at peace. We have less than 90, you see how your patient gets to the hospital, or the supervisor is informed immediately. So what are some factors that can affect SpO2? High altitude. For a person who stay in hilly places, again, this may or may not be the spectrum of patients. They may find that oxygen saturation may be lower because at higher altitude, the lower atmospheric pressure is lower. Then a patient who has chronic underlying medical conditions, like I said earlier, chronic lung disease, chronic heart failure, many of them would also have SpO2 levels that is a bit lower than normal. So this is the machine or the equipment used for monitoring SpO2. Most of them would also monitor pulse alongside. So the reading on top is the SpO2. You can see SpO2 written on top of it, and then you have 95. So this person has an arterial saturation of 95, which is considered normal. And then you can find the pulse here. Pulse is 90 beats per minute, which is also normal because normal pulse is 60 to 200 beats per minute. Okay, and I think on that note, we come to the end of this presentation. Now, do we have questions? Okay, so I want to assume that you understand it well.
Yes, ma'am.
Okay, there were these videos that we watched sometimes ago that I want to see if we can just use that to recap vital signs. And on that note, we come to the end of this lecture. Any question finally before we call it a day?
Question.
I didn't hear you. What did you say?
No question, ma.
All right. Thank you very much. Have a wonderful weekend.
Thank you.